Alright guys, this is chapter 13, Principles of Patient Assessment. This will be the first chapter we're really getting into what we're here to do. Alright, the objectives for this chapter are to define ABCs, accessory muscle use, auscultate, the AVPU scale, baseline vital signs, brachial pulse, BP-DOC, capillary refill, carotid pulse, chief complaint, crepitus, decap-BTLS, dorsalis pedis pulse, focused secondary assessment, general impression, guarding, immediate life threats, interventions, jugular vein distension or JVD, manual stabilization, mechanism of injury, medical patient, nature of illness, OPQRST, paradoxical movement, patient assessment, posterior tibial pulse, primary assessment, radial pulse, rapid secondary assessment, reassessment, sample history, scene size up, secondary assessment, signs, symptoms, track marks, trauma patient, tracheal deviation, trending. Objective number 2, explain the importance that safety plays at the scene of an emergency. 3, describe hazards commonly found at emergency scenes. 4, explain the role that the emergency medical responder plays in ensuring the safety of all people at the scene of an emergency. 5, describe the components of an appropriate scene size-up and importance of each component. 6, differentiate between mechanism of injury and nature of illness. 7, differentiate between a significant and non-significant mechanism of injury. 8, explain the purpose of the primary assessment. 9, describe the components of a primary assessment. 10, describe patients who are high and low priority for transport. 11, explain the purpose of the secondary assessment. 12, describe the components of a secondary assessment. Number 13, describe the components of the sample history tool. Number 14, describe the components of the BP-DOC assessment tool. Explain the purpose of the reassessment. Describe the unique assessment methods used for pediatric and geriatric patients. Number 17, demonstrate the ability to identify immediate and potential hazards to safety. 18, demonstrate the ability to properly perform a scene size-up. 19, demonstrate the ability to properly perform a patient assessment. 20, demonstrate the ability to properly perform a secondary assessment. 21, demonstrate the ability to properly perform a reassessment. Number 22, demonstrate the ability to properly identify and perform appropriate interventions during a patient assessment. Number 23, value the priority that safety plays in the overall assessment and care of the patient. Number 24, model a caring and compassionate attitude with classmates and simulated patients. Number 25, support the role of emergency medical responder with respect to patient advocacy. And finally, number 26, model an appropriate level of concern for a patient's modesty when exposing the body during an assessment. As you can see, we've got a lot of topics to cover in this chapter. Some of them will be review, some of it's going to be brand new. Just got a lot of information to cover. You're going to need to spend a fair amount of time in your book on this particular chapter as well as this lecture. All right, patient assessment. All right, a thorough patient assessment will be the foundation for the care of all patients. When you first arrive on scene, you've got to assess your patient. You can't solely rely on the dispatch information. Sometimes it's incorrect. You can't rely on the family members. A lot of times they may not know exactly what's going on. And even the patient may not completely be aware of what's going on. They may be aware of the signs and symptoms that they're experiencing, but they may not understand why they're feeling that way. So you've got to do a proper patient assessment on every patient. All right, EMRs are trained to identify, prioritize, and care for major signs and symptoms. EMRs do not try to diagnose the patient's specific problems. All right, so what's this saying is your job as an EMR is going to be to identify major signs and symptoms that a patient may have been experiencing, correct them, and try to help stabilize that individual. You're not trying to diagnose the base problem for what they're experiencing. You're going to look at signs and symptoms, and you're going to try to alleviate those. All right. EMR is also going to do assessment-based care. They're going to perform a scene size-up, a primary assessment, a secondary assessment including history, and a physical exam. Then you're going to reassess your patient. All right, scene safety is also a big one. It allows for rescuers to access and provide care to patients without danger to themselves. It's going to help you identify unsafe scene hazards that are immediate or potential for danger. You got to protect yourself. We went over this in the first chapters of this class. You got to protect yourself. Everything else comes secondary to that. You can't help anybody if you're injured. You should never dismiss the scene dangers in an attempt to be heroic. There's no need for that. You got to do the best you can while making sure you stay safe. All right, this is a figure of the patient assessment algorithm. This is going to be in your book. I'm not going to spend a whole lot of time on this particular slide. We've got a long way to go in this lecture, but it's 13.2. Make sure you take a look at it in your book. All right, so when you start your patient assessments, you're going to start with the type of patients you've got. So the four types of patients you may encounter are a responsive medical patient, an unresponsive medical patient, trauma patients with a significant MOI. MOI stands for mechanism of injury. Trauma patients without significant MOI, again, that's mechanism of injury. You're going to perform your primary assessment. This is going to detect and correct any life-threatening problems. All right, then you're going to move into a focused secondary assessment. For your responsive medical patient, this is going to be your flow chart. You're going to go with a scene size up. Then you're going to establish your chief complaint of the patient. You're going to complete your primary assessment, which means you're going to care for immediate life threats first. After that, you're going to obtain the medical history and move on into your secondary assessment. That's going to start off with vital signs. All right, this is a medical patient. The image just says that their chief complaint may not always be as obvious as you approach them compared to a trauma patient. A lot of times with the trauma patients, you can see your injuries. Sometimes you can't, but a lot of times you can. Generally, medical is going to rely on your assessment a little bit more. All right, so this individual has performed a scene size up, and she's making her initial contact with the patient, attempting to establish a chief complaint. All right, in this image, she's performing a primary assessment. Looks like she's counting her respirations as well as her heart rate at this point. Always remember to treat your immediate life threats first. This is going to be airway obstruction, severe difficulty in breathing, uncontrolled external hemorrhage. These are all things that need to be addressed immediately. All right, after she's obtained her primary information, she's going to move on to obtain a medical history. If you take a look, she's got medications in her hand. Medications can give you a big picture of what is wrong with this patient as far as chronically. Even if you don't know what they are, you can always Google the names of the medications and it'll give you what they're for. So you don't have to know every medication and what it's for to be able to use them. All right, so during this, she's performing her secondary assessment. Your secondary assessment does include vital signs. You can delegate some of this if you've got more than one person on the scene. You don't have to do it all yourself. All right, patient assessment. You got a rapid secondary assessment. This is going to be for an unresponsive medical patient. Initially, you're going to do your scene size up. Then you're going to do your primary assessment. You're going to care for the immediate life threats first. Again, airway, breathing, circulation, sometimes circulation, airway, breathing. Rapid secondary assessment. This is going to identify the signs of the illness. You're going to obtain a baseline set of vitals, and then you're going to reassess your patient and be able to trend and see how your treatment is working so far. This image just shows two providers walking inside. They're getting some information from this individual as well as starting to perform their scene size up. Alright, she's performing a primary assessment on an unresponsive patient. This is going to be just like what you would do in CPR. If you'll look, she's taking a listen and also looking for chest rise and fall. Alright, she's performing a rapid secondary assessment in this image. She's trying to identify the different signs of the illness. Got her partner obtaining some vital signs. You're going to reassess this patient as often as necessary. A good rule of thumb is 5 minutes for a critical patient, 15 minutes for a non-critical patient. Hopefully you'll have some assistance at the scene around that time. Alright, so a focused secondary assessment on a trauma patient with no significant MOI or mechanism of injury is going to go like this. You got your scene size up. You're going to do your primary assessment, which includes your ABCs. It's your focused secondary assessment based on the patient's injuries. Then you're going to reassess as needed. Alright, so they're walking up to the scene. They're performing their scene size up, making it safe for them to enter. Trying to decide if they're going to need any additional resources before they ever make contact with the patient. And this is something similar to what we could see around here. You got a lot of heavy equipment that's used, and there's a lot of potential for pretty significant injury. Alright, so they're performing a primary survey. Care for immediate life threats first. In trauma, a lot of times one of the most immediate life threats is going to be severe external bleeding that can't be controlled. You got to make sure you take care of that quick, or you're not going to have any option of anything else after that. Alright, so if you'll take a look at this, they're performing a focused secondary assessment based on their injuries. You see this individual's holding spinal stabilization manually right now, while this other provider does a assessment on him. She's currently assessing the stability of his pelvis. Alright, this is going to be a rapid secondary assessment for your trauma patient with a significant mechanism of injury. So the flow is going to go about the same for all these with some differences. You got a scene size up initially, then your primary assessment, which is where you're going to care for your immediate life threats. And you move on to a rapid secondary assessment. You're also going to obtain vital signs, and you're going to reassess. Okay, so you're going to perform your scene size up as you approach the scene. In this particular situation, I personally, with the horse being as close as they are, horse could get spooked. It's a large animal, could cause some issues for you and your partner. Probably not, but it's something to keep in mind. You may want to have somebody go ahead and secure this animal before you and your partner proceed to the patient. You don't want to get stepped on or kicked by spooking the horse. All right, they're performing a primary assessment, and they're also going to care for any immediate life threats. Again, you'll note he is holding manual spinal stabilization while the other individual is starting his assessment. We're going to assume that this individual had an issue with her breathing. She was probably breathing adequately as far as depth goes, but she just looked like she might have been working a little bit hard, so they applied a non-rebreather mask. Again, you'll note from an earlier chapter that can provide high flow oxygen and high concentration oxygen at a rate of about, or a concentration of about 90 to 95%. If you'll also note, he has exposed the patient so we can do an adequate assessment. Alright, so here's something to think about. You respond to the scene of an assault. The scene is safe. Your patient is lying on the ground, bleeding severely from an upper leg wound. You note snoring respirations. Alright, so what are your immediate actions? Okay, so in this particular situation, you've got two. You've got the major bleeding that needs to be controlled. You also note snoring respirations. Ideally, if you've got two people available, one of you can tackle the airway issue and one can tackle the bleeding issue. Personally, I'm going to go ahead and attack the severe bleeding. Uh, Especially in trauma, a lot of times you go circulation, airway, breathing. It's just something that you've got to get under control quickly, or you can't put that blood back in. It's gone forever. It would not be inappropriate to say that you were going to start with the airway either. We can discuss this more in class and talk about some differences of opinions. All right. So what are some additional components of the assessment you must complete? You've got to go through everything. You've got to go through all the different components of the assessment that we've discussed in the previous slides. If you'll take a look at that chart that I told you to in your book, it'll give you all the different assessment components. All right, let's move on to the scene size up. All right, scene size up. Safety is going to be the primary goal. It begins with the information you receive from dispatch. So you get the information you get from dispatch as it relates to the scene safety, but you can't assume that all the information is complete and accurate. They're only able to give you the information they're given from the caller, and sometimes the caller just can't relay the information that you need, so you need to do your own scene size up when you arrive on scene. Don't just take everything the dispatch tells you for fact. All right, you always want to make sure you take BSI precautions. This protects you and the patient. You're going to use disposable synthetic gloves, preferably. If you're using latex gloves, it just has the tendency to cause issues with individuals that have allergies for latex. Most healthcare organizations have moved away from using latex gloves. You can use eye protection if needed, and other personal protective equipment is needed. So here's something to think about. So say you arrive on scene and you're treating the patient for an ankle sprain. There's no bleeding externally, and he discloses that he has a history of HIV, which is obviously the virus that causes AIDS. You are wearing protective gloves. Do you require any further personal protective equipment? The answer to that is no. HIV is not transmitted through droplets through the air. HIV is not transmitted, via airborne. Your gloves are completely are enough to protect you. If you've got active bleeding, eye protection would definitely be recommended, and also covering your other mucous membranes such as your nose and your mouth. But for this particular situation, gloves is enough. All right. Next thing you're going to do is you're going to identify the MOI, which is mechanism of injury, or the nature of illness for a medical patient. All right, MOI, this is going to be combined forces that cause the injury. Nature of illness, this is going to be what is medically wrong with the patient. Complaint not related to an injury. All right. Determine the number of patients. Identify additional resources that are needed. Consider the need for spinal precautions. All right, so as you approach the trauma patient, take appropriate BSI precautions. Determine if the scene is safe for you simultaneously. Identify and evaluate the mechanism of injury. Determine the number of patients. Decide if additional resources, such as an ambulance, fire department, law enforcement, helicopter, utility company are needed. And also consider the need for spinal immobilization. All right, if you take a look at this image, this gentleman appears to have fallen off the ladder. If you'll take a close look at his legs, you get some pretty significant deformity. I also get some injuries to his his lower arm. All right, so this is your medical patient. As you approach the patient, take appropriate BSI precautions. Determine if the scene is safe for you and the patient, as well as bystanders. Identify, evaluate the chief complaint. Determine the number of patients. Decide if additional resources such as an ambulance, fire department, law enforcement, or helicopter are needed. Alright, scene safety. Never assume any scene is safe. If the scene is unsafe, do not enter it. Vehicle collisions in traffic, release of toxic substances, violence or crime, any weapon that may be there, unsafe surfaces, these are all things that make a scene unsafe, so you got to keep all these things in mind. So after you've determined the scene is safe and you arrive at the patient's side, identify yourself. Let them know you're a trained emergency medical responder. You're going to gain consent from the patient to provide care, keeping in mind that the patient may be unresponsive, and then what are you going to treat them under? What type of consent would that be considered? That's going to be implied consent. So don't hesitate to use implied consent to treat an unresponsive patient. How do the following situations affect your actions regarding the scene safety? Alright, so a motor vehicle collision on an icy roadway. So the collision's already happened. However, the roadway is icy, so you may have issues with your own vehicle. So you got to keep that in mind. You may have issues with other vehicles colliding into the scene because it's icy. So you got to keep that in mind. A situation like that, I'd probably go ahead and just block the entire roadway until I could get everything secured and get to a safe place. So a brawl at a bar with several bleeding patients. You could be assaulted. You could have individuals with infectious disease. You just got to keep that in mind. A domestic violence assault. These are very dangerous. Just a lot of issues that can go on there for you as well as the patient. An industrial facility where there's a report of a strong odor. This could be some type of hazardous material, and if you don't have adequate training dealing with hazardous materials, you could be setting yourself up for a bad situation. So you want to just stay out of that scene until somebody that with some appropriate training arrives.
Domestic violence is largely about power and control. The abusing person in the relationship uses violence to assert this control over the victim. Although the violence may seem to be motivated by anger or rage, the underlying concepts in domestic violence are power and control. Domestic violence happens in every city and every town. Domestic violence is not confined to any one socioeconomic, ethnic, religious, racial, or age group. While many consider domestic violence as a man against a woman, in reality, anyone may be a victim. Husbands may be battered as well as members of same-sex relationships. Accurate information on the extent of domestic violence is difficult to obtain because of extensive under-reporting. However, it is estimated that as many as 4 million instances of domestic abuse against women occur annually in the U.S., and approximately 826,000 children are abused by their parents each year. Thus, it is very likely you'll need to respond to injuries that are the result of domestic violence.
All right, let's move on to the primary assessment. The primary assessment is designed to help the EMR detect and correct all immediate life threats to airway, breathing, circulation, and bleeding. All right, size up the scene and form a general impression of the patient. You can evaluate the mental status of the patient. She's talking to him now, asking him questions, just trying to make sure he knows what's going on. Address any issues relating to the airway, breathing, and circulation. And if you take a look at what she's doing, she's controlling some bleeding, possibly pretty significant breathing, while her partner's continuing with his assessment. All right, determine the patient's priority for transport. All right, primary assessment. You're going to form a general impression of the patient. General impression means what does this person look like when I'm walking up. It's just an informal assessment. Just kind of tells me what I'm dealing with. You can assess the patient's mental status. You can assess the patient's airway, assess the patient's breathing, assess the patient's circulation, assess uncontrolled bleeding. You're going to make a decision on the priority or urgency of the patient for transport. All right, general impression. This is going to be the first informal assessment of the patient's overall condition. ABCs of emergency care. This holds true for EMR, EMT, advanced EMT, paramedic. It holds true for any situation involving the health of a patient. All right, so you can see she's sizing up the scene as well as getting information from the spouse of this individual. She's also gathering in her own mind the general impression of the patient that she's about to be treating. All right, she's assessing the patient's mental status here. Again, just asking him, do you feel where you at? Do you know where you are? What's your name? Just asking any of these questions. All right, she's doing her primary assessment. She's assessing the patient's airway, breathing, and circulation. All right, at this point, she can determine the patient's priority for transport. Is this patient critical, non-critical? All right, so when you're determining mental status, you're going to use your ABPU scale. You're really just checking for the level of responsiveness. All right, so is this patient alert, which means do they see you walk in the room? Are they tracking you as you walk in? Are they responsive to verbal stimuli, which means their eyes are closed, they're not tracking you, they're not aware of you entering the room, but if you say their name or make a noise to get their attention, they're going to look in your direction and become alert? Are they responsive to pain, which means they are not responding when you walk in the room, they're not aware of your presence? You can shout, call their name, speak to them, they're not going to respond. But if you cause them pain, they will wake up and become alert. Unresponsive means that they will not respond to verbal or painful stimuli. They are completely unresponsive and you cannot arouse them. Okay, if you'll see this individual, he's determining the level of responsiveness. Looks like he's using verbal stimulation and possibly some type of painful stimulation. You're going to ensure an open airway and adequate breathing. All right, next you're going to move for presence of a pulse. All right, you're going to look for and control all major bleeding. Determine the patient's priority for transport. Again, guys, like I said, your airway, breathing, circulation, and bleeding. Sometimes, depending on the severity of your other life threats that include airway, breathing, the bleeding part may need to be handled simultaneously with the airway or simultaneously with the breathing. The bleeding can't be overstressed. How you need to get that under control. All right, primary assessment. You can start with your mental status. If your patient is unresponsive, you may need to reposition to check for breathing, pulse, serious bleeding, or perform CPR. If the patient is unresponsive and breathing, there will be a pulse. There's no way that you're going to be breathing and not have a pulse. You may have a hard time palpating it, but there will be a pulse if they're unresponsive and breathing. If the patient is not breathing, check for a carotid pulse at the neck. A pulse at the wrist or the radial pulse may not be present if the patient's in shock. All right, this is just the image of the provider checking for the presence of a carotid pulse on an unresponsive patient. All right, this figure is checking for the presence of a radial pulse on a responsive patient. All right, so these two images, the responsive patient, generally I'll check a radial pulse. An unresponsive patient, you always go straight to the carotid. If there is no pulse, alert dispatch and begin CPR. The patient is not breathing but does have a pulse. The patient may have an airway obstruction or they may be in respiratory arrest. In this situation, you're going to look at doing some rescue breathing for the individual. Alright, check for serious bleeding. Blood that is bright red and spurting is generally going to come from an artery. Flowing blood that's going to be darker in color comes from veins. The major concern is for total blood loss. You want to keep that to a minimum, and you just want to attempt to control the bleeding. All right, these are some high priority patients that need to be transported immediately. Unresponsive patients, difficulty breathing, severe for bleeding and or shock, complicated childbirth, chest pain, or any severe pain. Alright, so let's get into infants and children. They are not little adults. They're often shy and distrustful of strangers. Open airway with the head in a neutral position. You may have to pad under their shoulders because their head is proportionally larger than their body. Breathing and pulse rates are going to be faster in a child. Brachial pulse in infants and a small child is better than a radial. Circulation checked by capillary refill, and the condition can change very quickly. They can't compensate as well as an adult can. Alright, checking for the presence of a brachial pulse in an infant. If you'll take a look at the image using 2 fingers right in the bicep area, you're just going to be compressing that artery against the humerus and you can feel a pulse. Alright, next thing we want to do is alert dispatch. You're going to give them an update of the patient's condition, mental status, age, sex, chief complaint, status of airway, breathing, and circulation, and any interventions and results that you were able to obtain. Now it says alerting dispatch, but if you've got direct radio contact with the responding EMS unit, you could also talk directly to them. What this is saying is you're just wanting to give an update on the assessment. That way it can be relayed to the responding providers, whether that's through dispatch or through direct contact with the responding unit. Alright, so here's a situation to think about. You respond to a motor vehicle collision with a 30-year-old driver and a school-age passenger. Remember, school age is going to be 6 to 12. The mechanism of injury is the same for both patients. It's going to be a car versus a tree head-on. They are both complaining of neck and back pain. How might your assessment and treatment differ? The 30-year-old and let's just assume they're a 10-year-old. Some of the assessment's going to be the same. You're going to do your scene size up. You're going to do your primary assessment, which is going to include airway, breathing, circulation, and severe bleeding. The only thing that's really going to differ is that you're going to have to be a little more aware of the younger child's maybe modesty and shyness. You also need to be aware that there will be differences in vital signs. The school-age child's heart rate and respiratory rate may be a little higher than the adults, which would still be normal for them. And you also have to keep in mind that child can decompensate a lot quicker than the adult without really showing any signs and symptoms of decompensation before they crash. All right, your secondary assessment. You're going to discover and care for specific injuries and medical problems. So this is your secondary assessment, meaning not your primary survey, which is airway, breathing, circulation, and uncontrolled bleeding. This is going to be for more specific problems. During this, you're going to obtain your patient history, a rapid secondary assessment, a focused secondary assessment, vital signs, symptoms, as well as signs. This is table 13.1. It's in your book. You need to spend some time looking over it. We'll go over it briefly here. For a trauma patient, you're going to look for a significant mechanism of injury. If that is the case, you perform a rapid secondary assessment. You're going to obtain vital signs and you're going to gather patient history. If there's not a significant mechanism of injury, you're going to perform a focused secondary assessment. So the difference between a rapid secondary assessment and a focused secondary assessment is if you've got somebody with a significant mechanism of injury, they may be unconscious, they may not be unconscious, they may have distracting injuries. You're going to check out their entire body and you're going to look for injuries. If they don't have a significant mechanism of injury, you can focus in on the area that they are injured and they're aware of themselves being injured in. All right, after you perform the focused secondary assessment, you're going to take vital signs and you're going to gather the patient's history. So for medical patients, if you've got an unstable medical patient, which is generally going to have an issue with their airway, breathing, or circulation, you're going to perform a rapid secondary assessment, gather patient history from the patient or the family while your partner is getting a set of vital signs. Again, for the stable medical patient, you're going to perform a focused secondary assessment. If they're not as critical, they'll be more able to let you know what's going on with them. And gather a patient history, and you're going to obtain vital signs. All right, objective findings. All right, they can be seen, felt, or measured scientifically. Subjective findings, they're influenced by the person and their opinions. So subjective can be different from person to person. Objective is going to be what it's going to be. Subjective is generally what the patient tells you. Objective is what you can see and find. Trauma with no significant MOI, you can examine the area the patient tells you is injured, obtain baseline vital signs, gather patient history. You're going to provide the appropriate care for the patient. All right, so this is them performing a focused exam. She's just examining the area that the patient tells you is injured. In this particular situation, looks like it's going to be the pelvis. This is the provider obtaining a blood pressure. All right, so she's gathering the patient history. Looks like she's using the bystander here to get some information. She should also be able to gather it from the patient since they're going to be stable. Okay, so they're providing appropriate care for the injury and transporting. In this particular situation, you may have an issue with the pelvis. She's putting him on a long spine board, which is going to protect his spinal column as well as stabilize the pelvis if it is in fact fractured. Alright, so a trauma patient. Some different mechanisms of injury for an adult would be ejection from a vehicle, death of one or more passengers in a motor vehicle crash, falls greater than 15 feet or 3 times the body height, rollover, high-speed vehicle collisions, vehicle pedestrian collision, motorcycle crashes, unresponsive or altered mental status, penetrations of the head, neck, chest, or abdomen. Here's some significant MOIs for a child. Falls of more than 10 feet, a bicycle collision, a medium speed vehicle collision. So when you're performing your rapid secondary assessment on somebody that has a significant MOI or an unresponsive medical patient, the first thing you want to do is stabilize the patient's head and neck, palpate the face and neck, apply a C-collar if it's appropriate. Then you want to move on and palpate the chest, each quadrant of the abdomen, pelvis, back, extremities, legs, and arms. You're doing this because they are unresponsive and they can't tell you what's going on. Alright, if it's an appropriate situation, you're going to stabilize the patient's head and neck, then palpate the head and face. This could be on somebody that we don't know if they've been involved in a traumatic incident, or if we know they have and we think they've got a significant MOI, we're going to go ahead and take stabilization of the spine. But just if you're unsure, err on the side of caution and go ahead and stabilize that head and neck. Alright, so you're palpating the patient's neck and applying the C-collar if you need one. In this particular situation, the individual is palpating the chest. He's looking for injuries. This is a situation where we're going to get into using our DCAP BTLS. We'll get into what that means here shortly. Alright, you can see here he's palpating the abdomen. Always you want to palpate in a responsive patient the areas that are not in pain first, and if they're unresponsive, palpate the areas that don't have any visible injury first. He's palpating the pelvis in this image. Alright, and palpate the back by sliding your hands under the patient. Just get as far as you can. You'll get a better look at the back when you get ready to put them on the spine board. Now you see us palpating all four extremities, feeling for any type of deformities. Again, we'll use the DCAP BTLS. Mnemonic, we'll get into that here shortly. Alright, so a rapid secondary assessment is basically just a quick head-to-toe assessment of the most critical patients. Alright, and you're going to interview an alert patient by asking their name. How old are you? What is going on today? How did this happen? Alright, how long have you felt this way? Has this happened to you before? Are there any current medical problems? Are there any medications being taken? Do you have any allergies? When did you last eat? Alright, so for a responsive medical patient, your focused secondary assessment is going to include signs and symptoms, allergies, medication, pertinent past medical history, the last oral intake, and the events leading up to the illness or injury. If you'll take a look at the first letter of each of these bullet points, it spells out sample. This is your sample history. Alright, so this is the individuals gathering the history of the patient. They're gathering information from him as well as his significant other, it looks like. Alright, so this is a responsive medical patient. So they're going to perform a focused assessment based on this patient's chief complaint. He's able to communicate with them. Looks like he may be complaining of abdominal pain since she's palpating the abdomen. You obtain a baseline set of vital signs. Provide the appropriate care as indicated. In this situation, she's placing a non-rebreather mask on this individual. Alright, so for an unresponsive patient, you're going to interview the bystanders. Ask them if they know the patient's name. Ask them if they saw what happens. Ask them if they saw anything else. Did the patient complain of anything before this happened? Did the patient have any known illness or problems? Does the patient take any medications? So when you're caring for an unresponsive patient, look for bystanders and family members for additional information since the patient can't give you information themselves. Alright, you want to locate medical identifying jewelry. This could be a necklace or a bracelet. Your first set of vital signs is called your baseline vital signs. This is going to include pulse, respiration, skin signs, and pupils. Alright, you're going to take additional vital signs at regular intervals. This is going to help you determine if the patient is getting better, worse, or if they're staying the same. Physical exam. If the patient is responsive and able to tell you what's going on, perform a focused secondary assessment based on the individual's chief complaint. If the patient is unresponsive, conduct rapid secondary assessment of the entire body. This is an assessment tool that we use. It's called the BP Doc. So this is going to be bleeding, pain, deformities, open wounds, crepitus, which is a grating noise or sensation felt when you're palpating the patient. This is another assessment tool. It's known as DCAP BTLS. This includes deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. Be a good idea to make some flashcards for some of these acronyms. It'll help you out. All right, check the head for bleeding, deformities. Examine the eyes for signs of injury. You're going to inspect the ears and nose for drainage. Inspect the mouth for foreign material, bleeding, or tissue damage. Check neck, front, and back for pain and deformity. Use both hands to inspect the chest, front, and sides for both pain and deformities. You're going to use both hands to palpate the scalp as you inspect the head. Use both hands. It allows you to assess more quickly and more thoroughly. All right, check the pupils for equality and reaction to light. Just using a pen light. Any light will do, even the light on your cell phone works. I use that pretty frequently. Alright, there they're inspecting the mouth for anything that may cause an airway obstruction. This could be teeth, blood, foreign objects that have found their way into the patient's mouth during the incident. And they're inspecting the neck for pain and deformities. They'll get front and back of the neck. Just run your hand behind the patient's neck, especially to feel for deformities. Use both hands to palpate the chest. Again, this covers more surface area simultaneously and also allows you to be more thorough. You can inspect the abdomen for trauma. Then inspect the pelvis, lower back for pain and deformity. Again, when you're assessing the back, get your hands as far under there as you possibly can. You'll get a better look at the back when you're putting them on a spine board, if you are in fact putting them on one. Examine each leg and foot individually. Examine the upper extremities. Check for distal circulation, sensation, motor function, and in each hand. This is just the provider inspecting the abdomen. It's palpating the pelvis for pain, deformity, and wetness. The wetness could be in the form of blood or urine. The incontinence of urine can tell us some things about the patient injury. You see he's got both hands trying to palpate up under the patient. Alright, so when appropriate and you're putting him on the spine board, you can see that he is leaned over and is checking the patient's back. Personally, I would, as the person that's more in line with the back, I would check the back if I was in her situation rather than his situation, but she is able to provide stabilization for the patient from where she's at. So this is also acceptable, but generally the person with the closer proximity to the back is going to be the one that needs to check it out. Alright, so in this one it's palpating the legs and feet for pain and deformity. That's the biggest thing you're looking for. Do you see anything that's broken, busted, or is the patient screaming when you're palpating it? Alright, so you assess distal circulation, sensation, and motor function of each foot. We'll go over how to do that in class. Alright, here you're going to palpate the arms and hands for pain and deformities. We're going to assess distal circulation, sensation, and motor function in each hand. In this particular image, he's just having the patient grasp his fingers and squeeze. That is covering sensation and motor function simultaneously. Alright, so OPQRST, this is another assessment tool that we use. It's going to be onset, provocation, which means what makes it worse. Quality, what does the pain feel like. Region and radiation, where is it located and does it radiate anywhere. Severity, how bad is it, scale of 0 to 10. Time, when did it start. It's table 13.2, it's in your book. It covers the general principles of patient assessment. Biggest thing is do no further harm to the patient. Don't cause any further harm just to be able to do your assessment better. And altered mental status is almost always a sign of a serious problem. Patients who appear stable may worsen rapidly. This is especially true in children. You must be alert to changes in a patient's condition. Monitor the patient's face for color changes. Unless you are certain the patient is free of spinal injury, assume that every trauma patient has a spine injury. Keep the patients engaged in your exam by telling them what you are doing. Monitor vital signs as frequently as every 5 minutes for an unstable patient. If it hurts, look at it and expose the area as necessary. All right, how might the head-to-toe assessment be valuable? So this is especially valuable if you got an unresponsive patient or a patient with distracting injuries. This gives you a complete image of the entire body, and you can look for any injuries or any signs of illness in the unresponsive patient or a patient that's not able to communicate effectively with you. What physical findings might be useful to decision making? It just depends on the situation. Anything that you find could make you treat somebody differently. Say you've got a respiratory distress patient and they've got major swelling and edema in their lower extremities. It may lead you to believe that they have some type of heart failure going on, something a little above the level of the emergency responder. But realistically, any signs and symptoms that you uncover during your exam can change the direction of the decisions you're making. All right. Can vital signs remain the same in a patient who is critical? Yes, they can. They can be stable vital signs. However, the patient could have something going on that's causing them to be unresponsive. And keep in mind that an unresponsive patient is generally always something serious going on. Are there other factors that might show you that a patient is declining? You've got to look at your vital signs closely. You need to be able to trend in your trauma patients, especially your pulse and your blood pressure are major indicators of a patient that's declining. In medical patients, respirations are a major indicator. So you just got to keep an eye on all your assessment findings and make sure you trend appropriately. All right, so you're going to repeat the primary assessment. You're going to ensure the ABCs are intact. You're going to reassess the vital signs. You're going to compare these vital signs with the baseline. Check and adjust interventions as appropriate. Hand off to the EMTs. Give the responding EMT or paramedic a verbal report. All right, how might the chief complaint change in a serious patient? So all scenes are dynamic. All patients are dynamic. For one example, if you've encountered someone who has chest pain, they may have chest pain now. As whatever situation they're experiencing progresses, it may change to a difficulty breathing. You just have to keep in mind every situation is dynamic, every patient is dynamic, and they can change quickly. All right, so you complete your initial assessment on a patient who has just over-ingested a prescription drug. How might you expect the ongoing assessment to differ? All right, it just depends on the type of drug they ingested. For this example, let's say a narcotic. So they overdosed on some pain medication. From your initial assessment to your ongoing assessment, you may see their mental status decline. You may see their respiratory status decline. Like I said, it just depends on the type of medication they've ingested. All right, summary. All right, patient assessments necessary to properly and completely examine the patient to determine the care needed. Detect the life threatening problems and correct them as quickly as possible. Always perform a scene size up. Make sure the scene is safe for you and other responders to enter. Gain information quickly from the scene, patient, and bystanders. Determine the patient's nature of illness or mechanism of injury. Determine if the patient is responsive. If spine injury or possible spine injury, maintain manual stabilization of the head and the neck. Make certain the patient has an open airway and adequate breathing as well as a pulse. Control all serious bleeding. Again, guys, keep in mind all serious bleeding is very important. And sometimes this needs to be controlled simultaneously with airway breathing. Just get it done quick. Our secondary assessment. You're going to look over your patient, check for medical identification jewelry, gather information, asking questions, and listening. Utilize the sample, BP, DOC, OPQRST assessment tools is available. Again, these are some things that you may want to make some flashcards for. Are you going to take the patient's vital signs? Head to toe physical exam is exactly what it says. You're going to start at the head, proceed to the neck, chest, abdomen, lower back, pelvis, genital region, and extremities. If you assist with the reassessment, note any changes in the patient condition or need for additional interventions. Now let's go over a few review questions. Why is safety so important at the scene of an emergency? All right, so you've got to maintain safety for yourself. If you're unsafe or you're putting yourself at risk of being injured, you're not going to be able to help anybody. Safety for you and other responders is number one priority. All right, what hazards are commonly found at emergency scenes? Medical, you could have issues with family violence. You could have issues with some type of substance that the patient may have ingested. You could have hazardous materials at the scene. For trauma, you could have major threats of traumatic injury for yourself. If it's a car wreck, you could have hazardous materials leaking. If it's a car wreck, you could also have fire. You could have electrical issues coming from power lines that are down. You can have airbags. I mean, it's just a really unlimited list. You've got to look at each particular scenario and think about what the possible dangers could be for each scene. All right, so what role does the EMR play in ensuring the safety of all people at the scene of an emergency? So you're going to be the first trained responder responding to emergency, so you've got to take a very active role in identifying any types of hazards before everybody gets involved. You've got to make sure no additional hazards develop. So you're going to just take a very active leadership role in determining the safety of the scene. All right, so what are the components of an appropriate scene size up and why is each important? All right, so when I'm arriving on a scene, first thing I'm worried about is scene safety. I'm worried about the safety of me and my partner as well as any other responding individuals, as well as the bystanders and people already at the scene. Next thing I want to do is do a triage, figure out how many patients I've got. Am I going to need any additional resources? Am I going to need any, special resources such as heavy rescue, hazmat, whatever? Make sure I've got my standard precautions on, make sure I'm protecting myself. Then I want to take a look at the mechanism or nature of illness. This is going to just determine how I go about treating the patient, what the next steps in my care are. So every step of the scene size up is important. What is the difference between mechanism of injury and nature of illness? Biggest takeaway from this is mechanism of injury is involving trauma patients, people that are physically injured. The nature of illness is generally going to be geared towards medical people or people that present with just signs and symptoms from no apparent trauma. What's the difference between a significant and a non-significant mechanism of injury? So a significant mechanism of injury, let's use an example, rollover, motor vehicle accident with ejection. This is going to be a significant mechanism of injury. It's going to be significant whether the individual is unconscious and unresponsive or they're responsive. This individual may have some distracting injuries, situations like this. A non-significant mechanism of injury could be isolated injury to the leg where the patient can tell you what's going on. You don't really have any distracting injuries going on. It's just going to be a less severe event that occurred that caused the injury. Now, what is the purpose of the primary assessment? All right, primary assessment's goal is to identify any life-threatening issues that are going on. What are the components of a primary assessment? Airway, breathing, circulation, as well as severe bleeding. Which patients would be considered a high priority for transport? This could be a large number of patients. Some examples would be unresponsive patients, patients that have been involved in a traumatic injury that's considered a high mechanism of injury incident, patients with difficulty breathing, patients in severe pain, There's a list in your book of patients that need to be transported quickly. I'm going to get you to refer to that. Which patients would be considered a low priority for transport? These are individuals that could benefit from transport, but it's not really time dependent. This could be an individual that has a complaint, no real irregularities with their vital signs, they're very stable. It's just somebody that time's not really going to change the outcome of their incident or event that they have going on. All right, so what is the purpose of secondary assessment? All right, the purpose of secondary assessment is to provide a more complete assessment of the patient as well as to obtain more information. What are the components of a secondary assessment? This is going to be a physical exam that includes vital signs as well as obtaining patient history. What are the components of the sample history tool? Sample history stands for S is for signs and symptoms. A is for allergies. M is for medication. P is for pertinent medical history. L is for last oral intake. And E is for events leading up to the situation. All right, so what are the components of the BP Doc assessment tool? All right, B stands for bleeding. P stands for pain. D stands for deformities. O stands for open wounds. C stands for crepitus. What's the purpose of reassessment? This is just to reevaluate what you've done, check on the patient's condition. Are they staying the same? Are they improving? Are they getting worse? It's just to reassess your individual and make sure you're keeping an eye on what's going on. All right, so what are the unique assessment methods for pediatric and geriatric patients? All right, so these are special populations that we've gone over in previous chapters. I'm not going to spend a whole lot of time going over this. You can refer to your book for it. But some of the things you want to keep in mind for pediatric and geriatric patients, some of the limitations they may have. Pediatrics may be especially shy. You also got to keep in mind that they can crash very quickly and won't give you a whole lot of warning. Geriatric patients may be hard of hearing, and they may have issues with other types of communication. Don't always assume that, but again, refer to your book for these special populations. Go over it, and we'll go over it more in class as well. All right, this is going to be the end of chapter 13. Hope you guys enjoyed it. Again, this is one of the first chapters where we're really getting into day-to-day functions as a EMR. I got a few more chapters in this section. See you guys on the next one.